first presentation is from a company you heard for the first time at CoinGeek London in February. It's EHR Data, who is here to give you an update about their development of a platform to transform how we engage, own, and monetize our own consumer healthcare data. Presenting virtually is a trio of their team. Ron Austring, who's their chief scientist, Cheryl Jorgenson, who's their chief clinical officer, and Joseph Eckstein, their director of product design. Please welcome to our virtual stage, Team EHR Data.
The biggest sickness in healthcare isn't a disease. It's not a bacteria, a condition, or a virus. It's the silence. You see, the data we need to cure cancer, or to stop suffering, to combat diseases, it's not out there, some unknown place waiting to be uncovered. No, no, no. It's stuck behind closed doors, on private servers, and in stubborn silos. Collectively, the healthcare industry has the data to improve our lives in untold ways, but shh. Do you hear that? That's the sound of no one talking to each other. And in that silence, countless lives are tragically ruined or lost. Because time alone does not heal all wounds. So we're not waiting any longer. At EHR Data, we're building the tools to assemble the largest ever data set of human health. And it won't belong to a hospital, a government, a corporation. It will belong to the rightful owner of your healthcare data, you. We're merging healthcare records with blockchain to finally put you in control of your healthcare, your data, and your health outcomes. You control your data. Personal, private, protected. You decide if your data can be used to research new treatments and medical opportunities. You determine who has access, exactly what they have access to, and for how long. Your healthcare data shouldn't be ones and zeros on private servers. It should be in your hands in service to your health. And now, it will be. The greatest sickness may be silence, but the silence stops when you have a voice. EHR Data. Own your health.
Hi, this is EHR Data, and our company was founded by Chairman and CEO Ken Hill. He had the forethought to understanding that patients' data needed to be aggregated into a centralized record. Patient safety was the primary focus for aggregating that data. Once you have data that is together in a global electronic healthcare record, you're going to be able to improve patient health and decrease health cost. And here in the near future, allow patients to be able to monetize their data, which is very important. They own that data, their clinical data. So in our current situation, the focus of EHR Data is patient safety, which is always going to rely on focusing on patients' healthcare and their outcomes. Now, in looking at our healthcare and in our industry today, we look at the epidemic with opioids. The opioid epidemic today, there's more than 150 to 250 people every day in the United States alone that demise over an overdose. And just looking at the United States, that's more than $78.5 billion that is lost in economic burden. This epidemic, this opioid epidemic, is still prevailing within our healthcare. We also have a pandemic with COVID-19. COVID-19 also enhances unfortunately, the use of opioids. With the mandatory lockdowns, patients are not able to get the help and assistance that they need, and the depression that comes along with it increases the use of opioids and increases the risk for respiratory depression. Now, the pandemic and the infodemic is something that we're seeing in the United States and across everywhere. It's not just a place where we're looking at we have issues. But the epidemic and the pandemic together has caused what I consider an infodemics. If you look at healthcare, we unfortunately have all of our data, it's siloed out. Doesn't take it's not rocket science that you can't treat a patient if you don't have all of the data together. And if you look at what our industry is today, we have multiple silos. There's no real-time clinical data. There's no workflow integration. There's no tracking of these clinical services. So the epidemic and the pandemic has caused us infodemics by having all of our data in disparate systems that are not joined together. We need to have the ability for all healthcare providers to be able to look at this data so that they can clearly make an educated and a clinical decision based on their patients. So we are looking at a proof of concept, and we are doing a proof of concept with the assistance of the St. Louis School of Missouri. And we're bringing all of healthcare data together so that providers can utilize this data to make the best decision. Now, looking at the epidemic and the pandemic with COVID-19, these are two instances that are going to help us open the door for inter and intraoperability of data. So in patients, when they receive and are prescribed opioids, there is a ability to calculate what we consider a morphine milligram equivalent, an MME. Now, what that calculation does is that it tells a healthcare provider the increased risk that patient has on a respiratory depression and an overdose. So the higher the number, the more the preponderance that that patient needs help and assistance in utilizing their opioids. So today, in the proof of concept, we will utilize that MME calculation for all of the prescriptions that a patient receives. It's calculated real time and accurate, and it's put into the patient's, into the healthcare provider's workflow. So they can use that data, and it's right there at their fingertips. It's pretty much an easy button for the healthcare provider. They don't have to worry about all of the calculations or am I missing some data because that patient might have received medication elsewhere. So when you have that morphine milligram equivalent, that is a way for a provider to take care of his patient to where they're not guessing or second guessing. So that MME calculation will be inter and intraoperable with that data. Along with the School of Pharmacy, the St. Louis School of Pharmacy, we are going to be opening up the proof of concept into other states, other integration. But if you look at the opioid epidemic and you look at the pandemics with COVID-19, we've had that infodemics of an issue of being able to calculate and have at a healthcare provider's fingertips the information that they need to take care of their patients. So COVID-19 testing, and then also here coming very soon, we're all hoping with the vaccinations. So lots can be attributed to the data. We can look at prospective and retrospective data, but the number one thing is that we need to have it all together. So our solution is not one that is just a basic solution, but a global solution, bringing the silo data together so that it is both inter and intraoperable, and doing so using Bitcoin SV blockchain technology so that we have one single source of truth for a patient to be able to have all of their data together and they own it. Now, the patient's ownership can be controlled with permission-based, which is so important because it is their data and they need to have it at their fingertips. A lot with this data for monetizing it can be utilized with patient loyalty programs. Being reimbursed, manufacturers need de-identified information to help when medications are released out onto, after they've been released, we need to have that supportive mechanism. Also, patients can have healthy habits, can be reimbursed from their insurance or from their self-insured employer. Preventative feedback and preventative care through the blockchain technology. The most important thing is that we have to propel patients in becoming consumers of their healthcare. Looking at everything that we have in front of us, the most important thing that we can share is the data, and that all patients' healthcare data matters, and having it together is where it is going to be the most benefit, decrease healthcare cost, and improve the outcomes for patients. And now I'd like to introduce my colleague, Joseph Eckstein.
Thank you, Cheryl. Good morning, good afternoon, good evening, all of you across your time zones. I'm going to take a moment to further elaborate on some of the development perspective details from what Cheryl talked about. So we started out with the Missouri proof of concept. That's our proving grounds. What we're trying to prove is that the system it's an inter-system data model. That means what we call that is interoperable. What we started with, we had an advantage. A lot of companies out there that have done this, an insurance company, they might have built their data model around an insurance card or a payer. A pharmacy may have built their data model around a prescription or the pharmacy itself. We've gotten the opportunity to step back and build this data model in both our database and our messaging around the person. So that has allowed us to act as an in-between, a middleman between pharmacies, between the transaction claim processors and the payers. We're using industry standards, communication methods that are already out there, so we can communicate with all of those individual entities, and they have to do as little work as possible, if any, to be able to integrate into the system. So we have built our data model around the fact that we are system agnostic. We're also proving out that our functionality is real time. Real time is important because there are a lot of solutions already out there in the industry where you have 24 or 48 hours to do your reporting, or you might have to manually log into a website and re-enter information that you've already entered into a separate system. Hopefully you enter it the same way. Because we are built on the industry communication methods that are already occurring between the entities, we're able to provide our services and add our benefit in a real-time synchronous manner. So that's important. Also, just to re-emphasize, we are built in to the process of the workflow. So the individual components, those entities, the systems that are already acting out there to move your healthcare from one to another, since we're built in to how it's working, they don't have to make changes, or they're making the smallest. It can be configuration changes or minor file changes to be able to participate with our offering. So we have the Missouri proof of concept, and the next step is to extend this proof of concept. We have proven that our system is interoperable. We can work with any chains, we can work with any of those processors, and we can work with any of the payers. And that means that we can scale. We can scale regionally, we can scale by state, we can even scale by country. Also, we can scale by drug type. The Missouri proof of concept has been focused on opioids and other concomitant drugs that go along with opioids, how we can help and prevent those overdoses. But there's nothing to say that we can't move to other types of drugs, to other types of services within that same workflow that's already occurring. So we built the foundation to very easily expand, and we plan on doing so. And also, we are proving that economies of scale and the benefit to them. So with economies of scale, when you have one entity that's holding this data, rather than lots of different payers or lots of different pharmacies, when you have one place where it's joined together, you're able to prove that you don't have to go to multiple places to perform your services. Rather, you go to one place and your transactions are faster. They're already tenths or hundredths of a second, but we're shaving that down even more. Also, when you don't have to go to 4, 5, or 6 different places where you have 4 or 5 different iterations of data, of the same data, you have more accurate data. So we're faster. Our data is going to be more accurate than any one individual can do. And also, since you're faster and more accurate, you then get the third benefit of having your data in one place. It's more valuable. Having the demographic data, having patient data, having prescription data, having payer data in different areas, it's good. But if you can't bring all that data together in one place, you can't make it as useful as it can be. It's also not as valuable because people want that data. In addition to the opioid epidemic, we are including COVID-19 in our early use cases. EHR Data has reached out, and we're partnering with a leading industry partner in both immunizations and COVID-19 clinical lab tests. We're working with them to add those records into our patient GPR, the global patient record. That's our centralized record for that person. Obviously, adding in their immunizations, adding in those lab records, tracking what's going on there, it will make that data more useful. We can solve more use cases for different entities that are trying to, as you're probably all familiar with what we're trying to do with COVID-19 and how to prevent the spread. And these are examples where in this integration with this partner is yet another example of how we're using those standardized data sets to help populate the GPR. The data sets we're using, for example, we're using the HL7 data set, and then over on the medical billing side, we're using the X12 communications. These are already out there in the industry. The entities are already using them to move their data, to identify their data, and to use their data. So we're capitalizing on that, again, so it's the least amount of work for any of the participants, our parties. So next, I'm going to change gears and briefly talk about data ownership. At EHR Data, as Cheryl said, we believe that this is your data. In our industry specifically, and even in the world, when things are occurring, when people are filling prescriptions, when they're offering the services you think you're getting, your data is already being exchanged. Your data, which we think is you, it belongs to you. It's already being exchanged between entities, and there are already transaction fees and costs going between those entities. We believe, since it is your data, that you deserve royalties from the use of your data. So whether or not it's your favorite social media news feed that is providing you a link that you should click on that they somehow know you'll be interested in, if it's your favorite digital book selling marketplace that somehow knows a brand that you're interested in, or if it's your search engine that has an ad and it already knows that this was a conversation you had earlier. Those transactions are occurring. The same kind of things are occurring in the healthcare world. They're moving, they're sharing your data. It is your data. We want you to have ownership and access to it. We're putting an electronic wallet on your GPR, that global patient record, to hold the value that is being exchanged. As Ron will talk about in just a moment, we have an authorization token that we use when any data comes into or goes out of our system. We know who it came from, where it came from, what application entered it, who it belongs to. We also know who's asking for it, where it's going, why they want it, what they've gotten before. So when we know it's coming in, we know it's going out, we know who it belongs to and who helped add that data. That allows us to put the value onto the digital wallet that's on the GPR, the global patient record. And since we're doing these monetary transactions, these exchanges, what better platform to use than Bitcoin SV to hold these immutable transactions? So now I'm going to turn it over to my colleague, Ron Austring, and he can, our EHR Data's chief clinical scientist, and he can pick up where he left off at last CoinGeek. Ron.
Thank you very much, Joey and Cheryl. So in February, I spoke at CoinGeek in London, and this was one of the final slides of my presentation. Today, I want to explain this slide in more detail, as there is a lot going on here. This slide also introduces the concept of data providers and data consumers. And it also shows payments going between each of the entities, which we will get into in more detail later. The lock in the center represents EHR data, and the lock signifies trust and a source of truth. So if we go on to the next slide now, I have a few examples of what trust is in the physical world and also the virtual world. So these are just, there's several examples here. And on my next slide, next couple slides, I'm just gonna talk about a few examples of that. So on the next slide here, in the physical world, when you want to meet with someone to purchase something, there's a certain degree of trust you decide to, you want to meet in public. So there's still a certain amount of trust that you need. If you don't know the person, you probably want to, maybe check them out a little bit. But also when you exchange goods, like when you receive the goods, you're probably going to inspect those goods and, make sure it's what you ordered. And the same thing for the person receiving the money. they're most likely going to verify that they got the right amount and, the money's proper money, it's not counterfeit. So this is, example every one of us are used to. But once again, there is a certain amount of trust there. On my next slide, when we get into the virtual world, there's a lot more trust involved, okay? And in this world, you'll most likely use an application that communicates through an API, which talks to a corporate server and goes down to a source of truth or trust through an API. Now, this source of truth or trust in our world would be EHR data. That's what we would be providing. On my next slide, what I want to talk about here is that this is a typical scenario that would happen in the real world, okay? So this is what would happen in a typical pharmacy doctor environment. So the patient in red goes to their prescriber and they get a prescription. So when they get that prescription, they leave there and they go to their pharmacy and they give the pharmacist the prescription. The pharmacist then enters that prescription into their system, and the problem here is that that prescription may not be filled for the drug that the prescriber actually wrote it for. So the pharmacy may fill it for generic, or they may have to actually change the dosage of it because they don't have the strength of the drug in stock. So what happens here is there's a huge disconnect between the prescriber and the pharmacy. So at EHR Data, we want to fix this disconnect. So on my next slide, before we get into all of that, what exactly is the EHR Data Utility? What is it doing here? Well, it's a healthcare data exchange based on trust. So we exchange healthcare data. It's designed to be a global solution. It's low cost, and it's transaction based, and mostly through an API, a real-time API. And the patient owns and permissions the use of their data. So on my next slide, what I want to go back to is that original scenario now, but this time the prescriber is actually hooked into EHR data. And so what happened, and the pharmacy. So what happens here is that when the prescriber writes the prescription for the patient, he also uses our API to push that data to the EHR Data Utility. Now when the patient goes to the pharmacy, he doesn't even really have to give him the prescription on paper. The pharmacy can look up that paper or that prescription on the EHR Data Utility. And same thing will occur. He may, change the drug to a generic. He may have to change the strength or whatever. But what's going on here now is that anything that he does is getting written to the EHR Data Utility. So everybody has visibility to this data, including the patient. So the prescriber has visibility, the patient has visibility through their mobile application, and the pharmacy has visibility. The other thing I want to introduce here is the concept of medical device data. So what could happen in this scenario as well is that the prescriber has given the patient heart medication, and they also want to track to see if that medication is working as expected. So what they prescribe is for the patient to wear a medical device. And in this case, it could be like any kind of medical device that can generate a heartbeat, a heart rate, and be collected. That could be an Apple Watch or whatever. So the green box here is actually, that device, and it's constantly putting data onto the EHR Data Utility. So if we go to the next slide now, what are the benefits of all this? Okay, so there's dramatic improvements in patient safety, patient-provider education, patient-provider communication and feedback, and patient outcomes. So as you can see, just from the previous slide there, that the prescriber can now monitor the outcome of the patient, so that they can track how their heart rate is doing based on the medication that they've been given. It's also dramatic improvements in clinical research. It helps reduce healthcare costs by the fact that everything is now more efficient. There's not redundant data entry and all of that. And it's the perfect platform for doing drug trial hosting, monitoring, and feedback. So if we go to the next slide, we'll see that the costs involved here are such that the utility is designed as a low-cost, transaction-based solution for exchanging and monetizing healthcare data. Low costs are important to drive adoption and promote efficiency. Healthcare system vendors lower costs by improved efficiencies, reduced data storage and infrastructure fees, and healthcare providers lower costs by avoiding redundant data entry, what we saw earlier, so that if data gets entered in one place, it doesn't have to be re-entered in another. Access to a complete picture of the patient's healthcare record. So everybody has visibility, all the healthcare providers have visibility to the complete GPR of the patient. There's also more abundant data. We've now introduced the concept of medical device data being captured. So there's just more abundant data to work with and access to all that data. All of this data is can be all de-identified when we do data monetization. In some cases, if they're in a drug trial, the data wouldn't be de-identified, but in most cases, when any of this data is monetized, it's all de-identified. So if we go to the next slide, what I'm going to show here is that in the bottom left of this slide is the scenario we saw earlier where the prescriber and the pharmacy are putting their data into EHR data. And that's shown here on the file folder on the top left. So when that data comes in, it comes into EHR Data's API, which we call EPO, EHR Data Permissioned Operations. From there, it goes into our database where we can interact with that for serving transaction requests. And then we also use a client of the nChain, so some software client. It's called the MetaNet Writer. And we communicate with nChain to actually have that data, whenever we want to write data, to the Bitcoin SV blockchain. And the way we do this is that the data will be written to an archival node. So the actual data will go to an archival node. So this could be, kind of a layered network approach. So if you saw Craig's presentation in February, he talked about Bitcoin layered networks, and today we saw Tal talking about layer 1 and layer 2 solutions. So these would be these archival nodes. That's how they would fit in. On the Bitcoin SV blockchain, we're only putting the hash. And the reason for that is it's medical data. And so we can't, because of different rules and regulations, we can't actually put the healthcare data right on chain. So we're doing a layered approach here. So if we go to the next slide now, I'm going to talk about real-time data monetization. So what happens now is the patient in the bottom left corner may go to another pharmacy. This pharmacy may be closer to their work where a different prescriber has prescribed them a medication. So they might end up at a different pharmacy. That pharmacy doesn't currently have them in their database. So they query EHR data, and we have the data. So through the API, we can actually deliver that data to them. So there's a transaction fee involved in getting that data. So when that transaction fee is paid, EHR Data will then pay the original pharmacy that actually entered all that data, the patient's demographics and the prescription data that they might need to do drug interactions and stuff like that, or allergies and stuff at pharmacy number 2 on the bottom. And the patient will also get a royalty because they own their healthcare data. So this is an example of real-time data monetization. If we go to the next slide, what we're going to look at now is batch data monetization. So this example here is with a drug manufacturer. It could be any kind of batch operation. It could be coming in from a third-party insurance payer or a company, like the actual employer group or whatever, may be interested in doing a query. But this example uses a drug manufacturer. So what happens here is they give us some criteria of how they want or what data they're looking for. We do a brief queries on our database to see how many result sets we would get out of that query, and we report back to them. If they agree that they want it, then they purchase that data. Once they've purchased that data, we put the result set together, and after that has been delivered to the client, we then pay royalties again. So the original prescriber in this case would be getting a royalty because he wrote the original prescription because they're interested in what that originally looked like. He also prescribed the medical device data, so he's getting credit for that. The patient is getting a royalty here because they own all the data. And the original pharmacy that actually entered the data, or pharmacies for that matter, are getting a royalty as well. So this actually shows how that would work. Now, if we go to the next slide, we'll see that this result set is quite complex. It involves different pieces of data. You know, it could involve patient demographics because they could be interested in zip code data or whatever. It's also the exact prescription information, say, you know, the dosage that was used, the drugs that were used, and how to take the medication. If it's heart rate data, we may need to run that data through another function to actually, because we have just the raw heartbeats recorded. So we may have to run that through another function. And that function could actually be supplied by a third party. So, you know, if there was another company that was really had expertise in this, they could hook into our process and actually supply that data or that function to provide the data for that query. So the end result set may go through some further processing, more functions here. But the bottom left one shows just, you know, we could deliver that data as just raw binary data, you know, just a raw result set. The middle one is meant to show graphical data that could be a result of us putting it into an analytical database such as Snowflake. And then on the right side here, it's we also could deliver a result set that could be fed into a graph database. So a graph database allows researchers to also see other similarities in the data, other dependencies that were kind of hidden in the data originally. So if we go on to the next slide now, what I want to show here is that the overall layers that go into our utility. So we have Bitcoin SV at the very bottom layer, which is, and that when you think of Bitcoin SV here, that could also be the layer 1, layer 2 archival nodes and stuff like that. So I just labeled it Bitcoin SV. We then have an N-chain layer for their technology, and then the EHR Data Utility. The flags here are meant to represent that within all this, we have to be in conformance with all the different government regulations. So in the United States, that's HIPAA, and in Europe, that's GDPR. At the next 3 levels up, it's a combination of applications and communication protocol standards and maybe clients of those applications, because sometimes there's a client-server kind of solution. I also want to point out here that EHR Data also has a couple applications. One of those is CareRx, and it's a clinical package, and MME Edit, and that's what Cheryl was talking about earlier. So we supply that as an edit to the actual engine, or the engine that the utility to actually process transactions as they come in. So if we go to the next slide now, we'll see that EHR Data is also developing mobile applications, and I'm not going to get into the details of all the different capabilities here, but I just wanted to point out that, you know, we're going to start with a person or patient mobile app, which will basically give them, as you can see from all these bullet points, access to their complete GPR, all their healthcare data, radiology images, outcomes, chat sessions, insights. Insights are delivered by the manufacturer, as Cheryl was pointing out. When a patient is on taking an opioid, we may want to deliver to their mobile app an insight video, just to educate them on the use of opioids and to caution them on the use. The other side of here is clinical and pharmacy, and providers and pharmacists. So that's the 3 mobile apps we're going to start with. We're also open to, I mean, we're developing our own mobile app, but this is all done through our standard API. So anyone can actually develop a mobile app if they wanted to, and use that in our network. If we go to the next slide now, I just want to play this video here, and what it's showing is this is a result set of a graph output. So as you can see, I'm circling here different people or persons' result sets, okay? So what we're going to do here is just zoom in on one of these patients and look at their structure here. So this is a MetaNet structure, actually right now in a graph database. We're represented as a graph database. And I'm just clicking around just to show you what kind of data we have here in their graph, okay? these could be, like I mentioned earlier, used by a researcher to make connections between all the other people in this result set to see if there's any commonalities, any common diseases or whatever. So this is just another one I zoomed in on. But as you can see, they're all different, and that's what makes us all unique. And it's like an identity in itself. Okay? So if we go to the next slide now, I just wanted to re-emphasize that at EHR Data, we take all of this personally. And I hope you get a chance to look at our video again. And it's very important to us that when you watch that video, that you are thinking about yourself, possibly as a patient, that you want all of your data available when in an emergency situation. That patient could also be your wife, your parents, your child, or whatever. So think about how important it is to have all your data in one place. And that does not exist today. So this is revolutionary, and we want to point that out. On our next slide here, I'm just in closing. I want to thank CoinGeek for having us, and also to just point out that we have a booth, and you can visit the booth, and we're going to be available to answer questions on those times on the slide. So once again, thank you very much.
The biggest sickness in healthcare isn't a disease. It's not a bacteria or a virus. It's the silence. See, the data we need to combat diseases, to stop suffering, it's not waiting to be uncovered. It's stuck behind closed doors in stubborn silos. The healthcare industry has the data to improve our lives in untold ways, but no one communicates. And in that silence, countless lives are lost. That's why at EHR Data, we're building the largest ever shared data set of human health. And it won't belong to a hospital, government, a corporation. It will belong to the rightful owner of your healthcare data, you. We're merging healthcare records with blockchain to finally put you in control. Because your data doesn't belong on private servers. It should be in your hands in service to your health. The greatest sickness may be silence, but the silence stops when you have a voice. EHR Data. Own your health.